speak about the Blepharitis secondary to Demodex.
Yeah.
For example, Demodex is every time more frequent in our meeting, in our conference. And with the Jett, we have the possibility to destroy with the electrical stimulation. We can destroy the capsule of the Demodex.
Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir. Thank you, as always, guys, for taking the time to join me here to learn and to grow. I have an amazing episode for you here with a wonderful guest who's going to teach us a lot about some emerging technologies in the eye care space. I have Dr. Vicente Rodriguez, who is an ophthalmologist based in the Gran Canary Islands. He's a corneal and refractive surgeon, world-renowned surgeon, multiple-time recipient of the gold medal of ophthalmological societies around the world. And he lectures around the world on various topics, in particular these days about the Jett plasma technology, which is something I'm sure many of us have heard of. And Dr. Rodriguez is the global medical director for Jett Plasma. So I'm very excited to dive into this topic and help us all learn more about this exciting new technology. Before we jump in, as always, I have one big request, which is if you get some value, and based on what I just told you, I know you're going to get a lot of value, but if you get some value out of this conversation, please share it, send a link to a friend, send a text message, put something up on Instagram, let us know that you were listening, let us know what you learned. So here we are. Dr. Rodriguez, thank you so much for joining me all the way from Gran Canary. Tell me, if you don't mind, please tell us a little bit about yourself before we jump into the Jett Plasma conversation.
Yes, thank you, Dr. Xiang. It is a very pleasure to be with you today, and it's a more pleasure for to have the possibility to introduce the Jett in the optometrist community in Canada. I know that the optometrists love, in general, the patients suffering about dry eye. And with the Jett, we will have the possibility to optimize the ocular surface in patients suffering of dry eye and blepharitis. I'm Dr. Vicente Rodriguez, Canary Island, Spain. Unfortunately for me, a little old, with more than 30 years of experience in corneal refractive surgery, in keratoconus surgery. I love the keratoconus surgery because in the Canary, with the sun, with the allergy, we have a lot of patients suffering of keratoconus, and to have the possibility to introduce the new treatment for that, the intracorneal ring segment, the different cross-linking, the epi on, the epi off, the accelerate cross-linking, the combining intracorneal ring segment and cross-linking is a big opportunity for our people suffering of keratoconus. And then, as a refractive surgeon, I can the possibility to see every time more dry eye in youngest population. 50% of our patients in our day-to-day in cataract surgery suffer dry eye, mild or even moderate dry eye symptomatology. And we need to consider before the cataract surgery, before the presbyopia correction, before the myopia correction, or even because the symptomatology, we need to treat and pay attention this every time more big group of patients in our day-to-day.
Yeah, absolutely. I think that is becoming more and more present. You know, we're hearing refractive surgeons talking about it more and more, about the importance of treating the ocular surface, optimizing the ocular surface to optimize the results afterwards. And that makes sense. You know, I wanted to kind of ask you the question, how did you come about, you know, even in diving into the world of dry eye as deeply as you have? And that makes sense because you're wanting to help your patients to have better results. So let's talk about the plasma pen technology. You know, we will speak specifically about this brand Jett Plasma, but the technology maybe a bit more broadly. When did you come in contact with this and learn more about that?
Yes, I will. My first contact with the Jett, I remember, was in 2018 in the World Ophthalmology Congress in Barcelona. But in this moment, my interest in the Jett is not for ocular surface. Was about the oculoplastic, non-invasive oculoplastic procedure
Okay.
and facial rejuvenation. I love, in general, of the feeling of ophthalmology. In some cases, I love to do blepharoplasty or CrossFit, and this is an option in 2018 because this device was developed initially for aesthetic medicine. But when I decide to begin with this technology, in this moment I am working with the IPL and with the LipiFlow in my clinic, and arrive the Jett, and we are using the Jett only for oculoplastic procedure and
Right.
facial rejuvenation. But when I understand the correct mechanism of action, I say, wow, this is amazing, because the Jett is not a laser. The Jett is not a radio frequency. The Jett is not a thermal pulse technology. The Jett is only, but enough, electrical device. And my father was engineer, electrical engineer. We talk a long time, many times, about the effect of the electrical stimulation in the body. And when I understand well the mechanism of action, I say, wow, I consider that the electrical stimulation we can use for treating dry eye or blepharitis. But in 2019, the company only used the device as ablative procedure with the golden tip, with the golden applicator. We can later speak the difference, the different applicator that we use. But the company in 2019 used the golden applicator for treat severe cases of dry eye with hyperkeratinization in the on the eyelid margin. And in these cases, it's not good idea to use the intense pulse light, for example, because the hyperkeratinization, you can drain the meibomian gland. And even, for example, with the LipiFlow, with thermal expression, it's impossible to drainage the meibum, because the hyperkeratinization in the eyelid margin avoid this liquefaction. I decide to use, in some cases, the embroc with the plasma discharge, broke the hyperkeratinization in the eyelid margin. And immediately, when you broke this hyperkeratinization, you can see again the orifice of the meibomian gland. And wow, this is really amazing. But I consider that the treatment is only aggressive, is very aggressive, and because it's painful, and we need to use a local anesthesia on the eyelid for treating with the plasma discharge. I think we need to modify the situation and use the direct current flow for treating mild and moderate cases of dry eye. And now, when I understand this mechanism of action, the low intensity direct current flow in contact with the conjunctiva, in contact with the skin, in contact with the eyelid margin, I think, wow, this is a revolution. Because I am working in this same time with the IPL and with the LipiFlow. And my good result with the intense pulse light is approximately in the 50% of the patients. Why? Why? Because the IPL was designed with anti-inflammatory effect for treating rosacea, facial rosacea. And when you treat facial rosacea, you can see that the patients are better about the dry eye. And this is the reason, because we use the IPL for treating. Dr. Toyos was a very amazing investigation for that. And decide, we are treating rosacea, and the patient is better too about the dry eye disease, or even in some blepharitis. And I decide Okay, in the patients, when I am not happy with the intense pulse light, how can introduce the Jett? And immediately I consider that in the conjunctiva stimulation, we can stimulate another parameter, another actors involved in the etiology, in the pathogenesis of the dry eye. For example, Gobel cells. The Gobel cells is maybe every people, the relationship in the dry eye is meibomian gland diffusion, but it's not only meibomian gland diffusion. In many cases of dry eye, we can have involved in the pathogenesis the Gobel cells, but in addition, we can have involved the orbicularis muscle or the rheolam muscle, or even the accessory lacrimal gland. And we need to add in all these points.
That's incredible. That's a lot of very important information there. I think one thing I want to kind of try to go through a few of those things step by step here. First thing that I love in general on the podcast, hearing about the backstory of how something kind of came to fruition and came to life. And I love the fact that your father was an electrical engineer, and you pair that knowledge that you received from him with your ophthalmology knowledge and experience, and you understand the value. So you understand now you are one of the few people that would uniquely understand the mechanism of action and how it applies to the eyeball and the structures in the eyes. Somebody could just tell me, oh, it's direct current. And I would say, okay, great. That's nice to know. But you actually understand what the direct current means versus, I assume, alternating current, and how that's applicable on the surface of the eye. So I think that's really amazing. And then you're able to take that and understand, one thing I want those who are listening and watching, if you haven't seen the Jett plasma, I encourage you after this, please just go search it. But it is a relatively small device, but it looks like a large pen. And you can apply it right to the conjunctiva. So palpebral conjunctiva and then the lid margin, as Dr. Rodriguez is saying, whereas most of the devices we're using right now, it's always on the outside, right? It's always in the outside of the eyelid, and we have to be careful.
And even in the fornix, because from time to time, we can have involved the aqueous component in the dry eye too. In the accessory lacrimal gland produce the basal aqueous component in the tear film, and we can modify this basal component if we stimulate directly the fornix on the conjunctiva. Every time we need personalize with the Jett. With the Jett, we can stimulate all the effort. With the LipiFlow or with the intense pulse light, we can stimulate specifically some parameter in dry eye. But with the direct current flow, we can stimulate the orbicularis muscle, the rheolam muscle, because it's very low. You have some problem in the back, and the physio decide to use electrical current for the stimulation of the muscle.
Right.
This is the reason, because we can stimulate the muscle even in the eyelid. And the orbicularis, every time the people blink less. 50 years ago, the population in general blink more than 50 times per minute. More than 50.
50 times per minute?
Yes.
Wow.
100 years ago, when we don't have TV, we don't have smartphone, we don't have computer, in the health of the ocular surface 100 years ago was better than now. And currently, we don't blink, and we need blink more time. I every day explain to my patients in my day-to-day, please, you need to blink more time, because I see to the face of the patients, don't blink, and speak. Please, please, blink. No, you say how many blink these patients has. Maybe 8, 9 blink per minute. This is absolutely directly to the dry eye. People blinking less than 10 times per minute finish in 20 years, in 10 years in children. every time in the next future, unfortunately, we will have more children with dry eye because the computer, because the smartphone, etc., etc., etc. And it's very easy. Blink. The population needs a little more. But if we stimulate directly the orbicularis muscle, the patients need to blink spontaneously. And when we are working with the Jett, with the silver applicator on the Jett, we are very near of the orbicularis muscle. And we can stimulate the superior, the inferior, and even near of the eyelid margin, we can stimulate the Riolan muscle. The Riolan muscle is around the meibomian gland. And when we stimulate the muscle, the Riolan.
Yeah. I think if we can think back to anatomy, I think we would all remember. I used to love anatomy, so I remember a lot of these random quirky things. But I remember the Riolan muscle right along the lid margin, and that's important for expressing the meibomian glands to release more moisture for the eyes. I actually remember that. And so that's really interesting. The physiotherapy analogy makes a lot of sense. We usually get that intramuscular stimulation to help the muscle kind of rebound and strengthen. And I just didn't think the Jett did that. I didn't know the Jett did that. That's very interesting.
The standard protocol initially was a little different. We are working only on the conjunctiva or in the eyelid margin. But every time we know more about the pathogenesis of the dry eye. It's very easy to contact with the Wolfram and with the Krauss gland, the accessory gland in the fornix. Because now we are developing new applicator longer. Because if you have with the applicator working in the conjunctiva for stimulate the fornix, we need to have a longer applicator, and in this time we can stimulate same time the conjunctiva and the fornix. We can stimulate the Goebel cells and the Krauss and the Wolfram accessory lacrimal gland in the same time, in 1 minute. In a very easy way. Separate the conjunctiva on the ocular surface, the cornea. But in a very comfortable for the patient and for the doctor, it's very easy to stimulate all the conjunctiva, and definitely at the end in the fornix, the Wolfram and the Krauss accessory lacrimal gland.
Very interesting. I didn't realize
in some cases. For example, every time in your meeting, I am sure in my meeting, we speak about the Blepharitis secondary to Demodex.
Yeah.
For example, Demodex is every time more frequent in our meeting, in our conference. And with the Jett, we have the possibility to destroy with the electrical stimulation. We can destroy the capsule of the Demodex.
Oh.
But for that, we need to modify the standard protocol. Normally, the protocol for the treatment of the dry eye is 2 minutes working on the conjunctiva in this position or in this position, in both. This is the applicator. We can work in this or in this position, no? But for the conjunctiva, normally we need to stimulate approximately.
Sorry, Dr. Rodriguez, before you continue, I just, for those who are listening, I want to try to clarify what you meant, what you said with this position or this position. Were you saying so the applicator would be sort of?
No, this is
parallel?
audio. It's mainly audio. Oh, sorry.
I would say most people are listening. Yeah.
Okay. I understand now. It's because I can see you, and I am thinking.
For those who are watching, of course, they can see the motion that you're making. That's perfectly fine.
Yes,
but I just thought, when you're saying that, were you saying the applicator would be, instead of being perpendicular to the conjunctiva surface, it would be like a parallel?
No, not perpendicular. You need parallel to the.
Got it.
Parallel. It's more comfortable.
I got you.
If you have a big for beginner. For beginner is more comfortable because the surface of the applicator is longer than the tip.
I see.
You use the tip in this position in contact with the conjunctiva. the longer is bigger space for a stimulation than the tip of the application.
Makes sense.
And the most important, the standard protocol. We can speak one more time about the standard protocol.
Yes.
2 minutes on the conjunctiva, 30 seconds on the eyelid margin, and 1 minute on the skin. But this is the standard protocol, for example, for meibomian gland diffusion. But if you have blepharitis secondary to Demodex, we need to modify a little, because the problem is not in the Krauss and the Wolfram meibomian accessory lacrimal gland. The problem is in the eyelid margin, is in the follicle. And we need to work a long time in the eyelid margin for destroy the direct current flow, with low energy direct current flow, destroy the without ablative procedure. It's only with contact and with the application, not the plasma, only direct current flow. But if we apply only 30 seconds is not enough. This is the reason, because every time we're in dry eye, we need to understand the diagnosis, to know exactly what is the axor, the main area that we need to stimulate, depending of the diagnosis. You have blepharitis secondary to Demodex, the problem is in the eyelid margin, and we need to use the stimulation probably for destroy all the Demodex, approximately 1 minute and a half, with very slow movement on the eyelid margin.
Interesting. And so this would be the tip perpendicular to the eyelid margin, like
exactly. In this case, perpendicularly.
Got you. Very interesting. I never knew that there was an absolute Demodex.
30 seconds is the standard protocol. In this case, if you are convinced that the etiology is the Demodex, you need to work maybe 1 minute or even more. And you can check in the slit lamp, you can check if you consider that the situation in the follicle changed.
This is incredible. This is, I'm learning a lot myself here. So I was, from the little that I knew about Jett so far, I was looking at it from meibomian gland dysfunction. So there's obviously function there, or application there, but you're saying accessory lacrimal gland, goblet cells, even Demodex. There's various applications for this one device. And in all of these cases, it's just the direct current at this point in time?
Yes, it's only direct current. In dry eye or blepharitis, we only use the plasma only if the patient has hyperkeratinization membrane on the eyelid margin. In this situation, you need to block this membrane. Without to block the membrane, it's impossible to have better result with our treatment. You can do the Jett in the same position, 2 minutes on the conjunctiva, 1 minute on the skin, 30 seconds. No, the result will be no good. This is the reason in many cases with the IPL, with the lipid flow, with the Rexon eye, we need to block the hyperkeratinization and open again the orifices. If we don't open the orifices, we can resolve the meibomian gland diffusion.
Makes sense. Okay, wonderful. I wonder if we can jump a little bit more into some of the, I know this won't be directly applicable for everybody right now, but I think it's really exciting to learn about. This is actually the initial application for the device was the ablative stuff. And then you discovered, with your knowledge of electrical engineering that you have, that the direct current could actually be very valuable for the dry eye. Can we jump back to the ablative? Could you tell me, what does the term plasma mean?
Plasma is an amazing technology too, because you can ionize a gas. If you have a gas and you apply electrical flow, in the other side begin the plasma discharge. You have a gas in the plasma pen with the Jett is the air. We ionize the air. If you ionize the air with electrical stimulation, in the other side is plasma discharge.
I see.
And you can see the discharge. It's very beautiful. The color, because it's very symmetric, it's very parallel, and only 100 micron diameter, only 100 micron diameter. But you can see if you are working approximately between 2-3 millimeter of the conjunctiva, because in some cases, for example, in ectropion, or in entropion, we use the plasma discharge for resolve this pathology. For example, I love the entropion with the Jett because it's a very easy way. In the standard surgery is very complicated for many doctors without a long experience in oculoplastic procedure, but with a non-invasive technology like plasma, is a few minutes for finish the procedure, and you need to do one triangle in the diameter of the entropion, one triangle in the skin, and apply the plasma discharge dot by dot in this surface. For example, if you have in the center the entropion in the center of the eyelid, and for example 1 centimeter, you need to do the triangle with 1 centimeter in the three side, and inside apply the plasma discharge dot by dot, separate approximately 1 millimeter, and you can see at the end of the procedure immediately the result, because the position of the eyelid move to the right position immediately after you finish the procedure. If the problem is not entropion, is an ectropion, we need to apply the dot by dot plasma discharge directly on the conjunctiva. See, you have in the one entropion in the first in the nasal eyelid, in the lower nasal eyelid. You consider 0.9 centimeter. You mentally think in a triangle on the conjunctiva, finish in the fornix, the base parallel to the lid.
Point is in the fornix?
Exactly. And you can discharge the plasma dot by dot directly on the conjunctiva. Unfortunately, all the procedure with plasma discharge are painful, and we need to use topical anesthesia in some cases, depending on the sensibility of every patient. I use Ophtesic. Is a product specifically designed for ophthalmology. Now, many surgeons use even for cataract surgery. Don't use the lidocaine intracamerular inside the anterior chamber. Use the lidocaine 2% on the corneal 5 minutes before the surgery. And in many cases, only with this lidocaine, you can do a topical cataract surgery. And we use the same lidocaine gel for many procedures, ablative procedure. For example, the conjunctivochalasis. Every time we can diagnose more conjunctivochalasis as involved in the etiology of the dry eye. In these cases, we can do the conventional treatment with the plasma, with the direct current flow. We need to do a ablative procedure with the plasma discharge directly on the area involved in the conjunctivochalasis, without any damage of the sclera or the retina.
Very interesting. I wanted to ask you about CCH, actually. That was my next question, so I'm glad you already jumped into it, because I've heard about that, and I find that a little scary, right? We're going to do this plasma treatment right on the ocular surface. How deep is it going? Is the sclera affected? Any deeper structures affected? So you're telling me it's just just the conjunctiva that is absorbing the energy? It's not going any deeper than that?
Yes. I have approximately in conjunctivochalasis. Fortunately, it's not every day, but I have been treating approximately directly in my clinic 2025. But every time I am visiting different hospitals around the world, and one patient suffer of conjunctivochalasis. Vicente, you can do the first case. Okay, I have more experience, but personally, in my patients, more than 20 patients treated with Jett, and with the first cases with a lot of the control with fundus, with the fundus camera. We analyze the retinal with the direct and direct ophthalmoscopy, etc., etc., etc. Now I can check even the retinal after the procedure, because I consider that the procedure is very safe.
That's actually really good to know. Really good to know. I love these potential. I mean, in the case of in the world of ophthalmology, of course, these are actual applications right now. But in the world of optometry, potential applications in the future as our scope expands over time. I don't know if we'll be able to do conjunctivochalasis treatments anytime soon. But the other ablative, like on the eyelid, I know that there are some jurisdictions where removing skin tags and things like that is allowed.
Chalazion, for example, maybe chalazion you can treat, because the treat with the chalazion is only with the direct current flow.
Mm-hmm.
You don't need to use the plasma. Is exactly the treatment is exactly the treatment of dry eye, but concentrate in the area of the chalazion, round the chalazion, until you can see the mabel. When the mabel arrive in the ocular the ocular surface on the conjunctiva, you can introduce the tip inside the capsule of the chalazion for finish, and remove inside. You can consider that the mabel is liquefied, and finally you finish the treatment inside the capsule of the chalazion. And
when you say inside the capsule, what does that mean?
Every time in the chat of a user, a lot of people, even optometrists, present different cases of chalazion treated with the Jett.
Yeah, that's one area where I think it's immediately applicable in optometry as well. When you say inside the capsule, what does that mean exactly when you finish inside the capsule?
Yes, because the chalazion has a capsule, and we need to break this capsule to resolve the case. If you don't open the capsule that involve the chalazion, the problem continue. We need to break the capsule until the capsule is closed. You need to work around the chalazion, on the chalazion, around the chalazion, 1 minute, 2 minutes, 3 minutes. Normally, using the right energy, in the most of the cases, 2 minutes and a half is enough for open the capsule, and you can see the mabel on the surface and finish the problem.
Gotcha.
In my case, I prefer upside on the skin, and even in the orifice involved. Every chalazion has a meibomian gland involved in the etiology. I prefer to do some second of direct current stimulation on the skin in the same area that the conjunctiva, and even a little on the orifice, directly on the orifice involved in the chalazion.
Excellent. Really exciting. Very interesting. I know there was a note here about, we wanted to talk a little bit about lid wiper epitheliopathy, because I think that's quite common, maybe more common than we're talking about it. But what's the application for Jett for lid wiper?
The lid wiper epitheliopathy.
Yes.
Yes. This is an inflammatory condition. Unfortunately, in many cases, the first etiology is in contact lenses wearers. And is every time more frequent because the patients use more time than the correct time. And this is the reason, because every time more patients consider the best option scleral contact lenses, because we protect the cornea with the scleral contact lenses. But the lid wiper epitheliopathy is very frequent in the big group of patients user of contact lenses. And the treatment is very easy, because we need to stimulate in these cases. We need to stimulate mainly the conjunctiva, the tarsal conjunctiva. The problem is very near of the eyelid margin. The lid wiper area is very near of is approximately 2 millimeter and separate to the eyelid margin less than 1 millimeter. It's in the distal area, very near of the eyelid margin.
Yeah.
And I recommend to stimulate all the conjunctiva because in the second etiology of the weeper is the meibomian gland diffusion. Specifically, the meibomian is the two big etiologies: the contact lenses wearers and the meibomian gland diffusion.
Yeah.
Even in patients without contact lenses user.
Yeah.
And in these cases, we need to stimulate all the suffer, the affect area and the other area of the tarsal conjunctiva, because we can have in the most of the cases involve the meibomian gland too in this diagnosis. And we concentrate, maybe in this case we don't need to use the skin, only working on the conjunctiva and working on the eyelid margin can be enough for treat the lid wiper epitheliopathy. It's very important because I don't mention in all the interview. In all the cases, working with the direct current stimulation, with the direct current flow, we need to use in all the cases a gel. We need to work on the gel.
Right.
Not only on the conjunctiva and on the skin, on the eyelid margin. And it's very common in your center, in your clinic, to use hyaluronic acid gel or another that we use for our. This is enough for the treatment.
I see. Okay.
Because we need to have a conductor gel. It's an electrical stimulation procedure. And for all the electrical stimulation procedure, we need to conductor gel during the treatment. This is very important. And sorry, because I don't mention before, but
that's okay. I don't expect anybody's going to be using it.
It's not a dry treatment. It's not a dry.
Right. We need some sort of.
I know some doctor in France, some doctor that recommend to do the treatment without gel. But I consider that the effect is greater if we use the correct gel conductor during the procedure.
Gotcha. Good to know. All right. We're going to, as we get closer to wrapping up, I wanted to ask you, one last thing, sort of a combined question. First of all, anything we wanted to talk about that we missed? And what are some maybe future applications or indications for Jett plasma that you're excited about?
Oh, for me, I am in another wave. In this moment, the current indication of the Jett is not enough to be excited. I need to think about what is the next step. In my opinion, the next step can be in the optical nerve. For me, the next step can be in the retinal surface. Really? Because every time we have more evidence that the electrical stimulation can regenerate, can maybe use the regenerate is very strong, but near of regenerate the structure in the retina, and maybe in the future we can have the parameter and the applicator adequate for treating the stimulation in the optical nerve or even in the retina.
That's very exciting. Wow.
Another question for the next future, and I have a lot of experience, but only in pets. For example, the facial paralysis. We have a group. I collaborate with veterinary ophthalmologists, and now in the next European meeting of the European Ophthalmology Veterinary Society, I know that some team or some group of veterinary ophthalmology, are presented or won't present different cases of facial paralysis
in animals.
Treated with the brother of the Jett in veterinary field.
Interesting. So same technology, but it's just applied in veterinary.
I don't have experience in human at the moment, but it can be a door that we can open for the next.
Yeah. Interesting. There could be some relationship. No, that's very interesting. I've learned a lot today in this conversation, Dr. Rodriguez. I really appreciate that. This is certainly exciting technology that has applications, of course, in the aesthetic space and, of course, dry eye and beyond in these ablative procedures around the ocular surface. So really exciting. I look forward to seeing more of this and how it's going to help move the profession forward, both ophthalmology and optometry as well. Thank you, Dr. Rodriguez, for taking the time to be here. I know you're a very busy man, and
Thank you,
thank you,
Harbir. It was a pleasure. It was a big pleasure.
Yeah,
I will ready for you and for the optometrists involved in dry eye in Canada in the future if necessary.
Thank you so much. Thank you. And thank you to everybody who's listening and watching the 2020 podcast, Canada's #1 optometry podcast. We'll see you guys in the next episode.